All right, well, I think we've got 10 people. That's a quora. I'm going to start. So welcome everyone. Tonight's talk is on syndromes, dysplasias, and metabolic disorders in children. This is one of my favorite topics because I quite enjoy all the weird and wonderful things that we see. Most of these conditions are quite rare. So, you know, if you see some of these things in your career, you'll be lucky, but then some of them are more common, and it's important to just have an approach to all these conditions. Right, so let's go. So just a brief recap of bone metabolism, and this is something that I have to reread every time I give this talk because I tend to forget these things, but this is just the cellular aspect of bone metabolism. So we know we've got osteoblasts and osteoclasts, and the key molecules, or like I said, things here would be rank and rankle. So rank stands for receptor activator of nuclear factor kappa beta, and rankle is all of that with a ligand at the end. So what happens is that osteoblasts actually secrete rankle that then binds to rank that lives on the pre-osteoclasts, and the rank then converts the pre-osteoclast to osteoclast, and osteoclast can function. And that's why drugs like the bisphosphonates that inhibit the binding of rankle to rank, amongst other things, and also inhibits the border thingy of the osteoclast, decreases bone resorption. And then an important other hormone or molecule in this metabolic pathway is osteoprotegerin, which is secreted by osteoblasts as well. And if that binds to rankle, then rankle can't bind to rank, and therefore you can't have osteoclastic activation. And interestingly, estrogen actually upregulates the expression of OPG, which is why we see such severe osteoporosis in postmenopausal women, because they lose their estrogen. Anyway, it's not relevant to pediatrics, but nonetheless. Yeah, so calcium homeostasis is another important thing to understand when you're looking at metabolic bone diseases. So it's essential for functioning of nerves and muscles. And this is your extracellular, or your intracellular calcium that functions within the cells. So the skeleton is a major reservoir for calcium, phosphate, and other minerals. And the body is geared to maintain the intracellular calcium levels above the extracellular levels, which means that if there's hypocalcemia for any reason, the priority will not be the skeleton. It will be functioning of the muscles and nerves, everything about the heart, etc. It's all geared or promoted by calcium, amongst other things. There's a complex interplay between minerals and hormones, and several organ systems are involved. So just briefly, parathyroid hormone, its main action is that a decreased serum calcium will lead to an increased serum PTH, and then PTH's function in combination with vitamin D, so it doesn't actually function independently, will be to release intracellular calcium to the extracellular space, increase calcium absorption from the gut and kidney, stimulate osteoblasts to release rankle, and then therefore have more bone resorption, and then also decrease the renal reabsorption of phosphate. So you'll basically lead to an increase in serum calcium and a decrease in serum phosphate. Then another thing is vitamin D. So UV light converts ergosterol and 7-dehydrocholesterol to calciferol and cholecalciferol in the skin. And that's then converted first in the liver and then in the kidney to the active variants of vitamin D, which is either 125 or 2425. So 125 is a more potent one, and therefore if you have a decreased parathyroid hormone, increased serum calcium and phosphate, you will have a preferential conversion to the less active variant of vitamin D, as your body requires, based on your body's calcium needs and vitamin D. Okay, and then there's other hormones. I've already mentioned estrogen that increases bone density by decreased activation of rank through upregulating of the OPG expression. Then the thyroid hormones, which activates osteoclasts more than osteoblasts, and that would explain the osteopenia and Brown's tumors that we see with hypothyroidism. Oh no, that's hyperparathyroidism, right? Sorry, forget about that. The thyroid Hyperthyroidism will give you osteopenia. Corticosteroids, the way they cause osteopenia is by increasing urinary calcium excretion, which leads to an increase in PTH, which leads to increase in calcium resorption from the bone. And then calcitonin is the only one that actually decreases bone resorption and renal reabsorption of calcium and phosphate. So the first condition we're going to talk about is rickets. So rickets is the pediatric form of osteomalacia, and it's a net effect of decreased vitamin D and calcium basically in the body. So it's a failure of mineralization of newly formed bone interfaces. That's why we see all these typical X-ray features of rickets, specifically around the facies. The adults obviously don't have facies. Therefore, osteomalacia is a failure of mineralization of newly formed bone in the cortex or in trabecular bone. So it's not the same quite as rickets. So the clinical features of rickets is a history of hypertonial weakness, although we don't usually, that's not very pronounced, delayed milestone, short stature, abnormal gait, and deformity. And the classic features, and there's a few of you who's been through Red Cross and Mater Cottage have seen these patients with a frontal bossing, rickety rosary. So the rickety rosary is actually widening of the physial junction at the costochondral, or widening of the costochondral junction of the ribs. So the same way they get widening of their wrist joints and other joints, they get widening of that interface between bone and cartilage. And that's why you get the rickety rosary. Then there is an sulcus, which is basically an indentation at the lower part of the rib cage, widening of all the joints, and then long bone deformities. And the radiological features we know is physial widening and cupping, coxa vera, long bone deformity, loser zones, and protrusio acetabula. But there are various causes of rickets, as we know. I mean, it's a net effect. It's almost more a symptom than a diagnosis. So you need to understand or figure out what the cause of the rickets is. And in our population, or currently in South Africa, the most common causes we see is either renal or familial hyperphosphatemic rickets or other causes of rickets. It's very seldom pure nutrition or pure vitamin D deficiency. So I'm going to start at the top of my list. Oh, Ashley is the other one that's writing now.
Yes.
Yes. Okay, so now you're there. Okay, so let's start with Bayanda. Just have a look at this X-ray and those blood results. So it's a 15-year-old male with progressive genovalgum, and those blood results. And I have the normal values there for you. So what are your thoughts?
Okay. So the calcium is high, phosphate low, PTH excessively high. I think this is hypophosphatemic rickets. You want me to describe X-rays, Dr. Horn? Sorry.
No. I wanted to look at the blood results. So, I mean, this patient has a marginally increased calcium.
Yeah.
But a very high parathyroid hormone. So is this primary or secondary hyperparathyroidism?
This is, why am I confused?
So increased serum calcium will probably lower your parathyroid hormone values, isn't it?
I just hit a blank, Dr. Horn. I'm not sure.
So this is primary hyperparathyroidism in this patient. So his serum calcium is elevated because of his extremely high PTH, as opposed to his PTH being marginally raised by a very high serum calcium. And then the phosphate is a little bit low. So if you look at, just to go back to that slide, parathyroid hormone, so decreased serum calcium will increase the serum PTH. So you won't see in a secondary parathyroid hyperparathyroidism, you won't see high calcium and high PTH.
Okay.
It will be the other way around. But what PTH does is it increases serum calcium, but it also decreases the renal reabsorption of phosphate. So a primary hyperparathyroidism will give you a highish calcium and a lowish phosphate.
Okay.
Yeah, so that's what I meant, is to understand the bone metabolism and how it works is important in making the diagnosis in this case. So, yeah, so if he had a hypophosphatemic rickets, he would have a much lower phosphate than that. Anyway,
Okay.
so that was the primary hyperparathyroidism from a tumor, from a pituitary, from a, what do you call it? Was it pituitary? I can't remember now, but he had an adenoma. I think he had a parathyroid adenoma. So that's what caused this disease. And then we fixed it. Now he's straight. Okay, so next on my list is Benjamin Blankson.
Hello, boss.
Hi, Ben, how are you?
I'm good. Good evening.
Good evening. Okay, so here are the x-rays of this young girl, 3 years old, presents with bow legs and a waddling gait, and she also has short stature. So just based on the x-rays, what is your diagnosis?
She's got both long bone bowing with widening of her physis, with what looks like the champagne glass appearance. So I'll be more inclined towards rickets.
Yes, okay. So we are talking about rickets, so that was a bit of a no-brainer. And she also has Coxa-Vara.
Yeah.
Yes, exactly. So these were her blood results. Just take a moment and read through it, and then you can tell me what you think the underlying problem is.
So her phosphate is low. Alkaline phosphatase is high.
Yeah. Expect that, no?
Urine phosphate is, or urine creatinine ratio is 8.6. No calcium.
They don't have the normal ranges here, but that's high. So the inorganic phosphate in the urine and the phosphate to creatinine ratio is raised.
Yeah. So most likely a hypophosphatemic rickets.
Yes, exactly. So she has familial vitamin D resistant hypophosphatemic rickets. Yes. So it's an X-linked. I think it's dominant, X-linked dominant inheritance. She was a spontaneous mutation, however. Do you know what the treatment for this is? The medical treatment. Massively high doses of phosphate and vitamin D, basically.
Yeah.
So you just flatten them to death with phosphate and vitamin D, and it's actually quite a difficult protocol to adhere to because of the side effects. So they get a lot of gastrointestinal side effects from the high dose phosphate, but that's all you can do. So that's the treatment for that one. Okay, and then last rickets patient for Omar. I haven't seen him online. Omar, are you on?
No, he's not.
No, he's not. That's very good. Okay. He is a big black.
Ashley is. He's also writing.
Yes, yes, yes. Oh, no, I know. And so it's Mohammed. So I'm just going down my list. Mohammed. Just have a look at this one.
Yes, boss. How are you? Good. Okay. So this is pictures of the lower extremity of the child, the skeletally mature patients. What I can see, obviously, there is a. So I'm not sure if there's a Coxa-Vara or not, but definitely there is a cupping and widening of the physis as well. Looking at the forearm, the distal radius, there's a flaring and metaphyseal, what do you call the flailing of the metaphysis and some fibrillation changes in the physis, which basically typically with the rickets patients.
So it's actually important for you to know this, guys. I examined 2 exams ago, I think at the end of last year's exams, and one of the pathology questions was just a picture of a wrist with rickets.
Yeah.
And yeah, it wasn't widely recognized by the UCT candidates that I examined. So obvious thing to look for. Okay, this is that one's blood results.
Okay, I'm just going to focus on the one with say low and high. So sodium is not really. Calcium is low. Alkaline phosphatase is quite high. And the parathyroid hormone is high as well. And vitamin D is significantly low as well. So the low vitamin D and PTH is compensated high. So probably vitamin D deficiency or vitamin D related rickets based on this blood.
So this is, yeah, well done. So this is the single case of nutritional rickets that I've seen in my career so far. And it was because this patient's parents were vegans. So he hasn't seen like butter or milk in his life. So he had like complete, just like very severe vitamin D deficiency. And once he was, his diet was slightly altered, his rickets healed. So this was, I think, a few months after those previous x-rays. This was the healing of the rickets. Yeah. So, okay, well done. Now, that's quite rare. All right. So the management of rickets is to correct the underlying metabolic abnormality, if you can, and then deformity correction, which can be done either by guided growth or acute correction or gradual correction with osteotomy. So this is a paper that I wrote when I was a fellow on low limb deformity, and guided growth works very well, but it's essential to address the underlying metabolic abnormality if that's going to work. This is just another case example. The 15-year-old boy presented us with severe lower limb deformity secondary to rickets of unknown cause at that stage. So subsequently, he's also been diagnosed with probably hyperphosphatemic rickets. Those where his deformity is very extreme. If you look at his legs, I mean, he couldn't fit into a single X-ray. It was just too severe. So he had acute 2-level osteotomies of the femurs and a TSF applied to his femur. And now tibia, and he's had both sides done now. He's still busy with the left side, but you can see the mechanical axis has been restored on the right, and he's now approximately 20 centimeters taller. Yes, Brianna.
Hi, Juan. So I know initially when we describe rickets and we talk about normal abnormalities, we talk about Coxa-Vara and genu varum. However, having rotated to Maitland, can we put our heads on the block and say genu varum, or just say lower limb deformities? Yes, in the hip, it's mostly Coxa-Vara, but what I've seen is mostly genu valgum and not genu varum.
Yeah, no, you're right. So I think you can say lower limb deformity, that is safer. And certainly the few severe rickets patients I've treated at all had valgum, even though they might have various of the femurs. So for instance, this guy had a varus femur, but severe distal femur and proximal tibial valgus, and his overall alignment was valgus. And the next patient I wanted to show you basically has the exact same deformity. This is also a rickets, and this is due to some renal condition, but basically leading to hyperphosphatemic rickets. And these were starting x-rays, and then following bilateral lower limb surgery, this was her last standing x-ray, as you can see. So this works very well for the severe deformities. I mean, you can't correct that degree of deformity with guided growth, especially if there's so many multiplanar deformities involved. Okay. So that's rickets. So we're going to stick to the soft bones for the time being, and then we'll move on with the other ones later on. Okay, so osteogenesis imperfecta. This is relatively common. It's one of the more common conditions that you'll see in pediatrics. So it's always caused by either a quantitative or a qualitative abnormality of collagen type 1, and a myriad of genetic mutations have been identified. So that's not really useful to us to know exactly which gene was involved. Doesn't change our life at all. So we stick to the very simple silence classification, or silence, I'm never sure how to pronounce this, where we know there's type 1, 2, 3, and 4. 3 is the ones that die. No, 2 is the ones that die. 3 is the most severe survivable form, followed by 4, and then 1 is the slightly milder ones. And then there are these other types, and these are extremely rare. That I'm gonna, so the type 5 is hypertrophic callus formation, ossification of the intraosseous membranes, and this is of the forearm and the lower leg, and radial head dislocation. And they actually don't have a collagen defect, same as type 6, which is like type 4, but without the collagen abnormality, and then type 7, which gets rhizomelia and coxa vera. But I think if you guys know the 4 first ones, then that's probably more than ample knowledge for OI. So we know the clinical features, but just to recap: bone fragility, deformities, and short stature, of course, hyperlaxity, scoliosis, say the tibia, blue sclerae only in type 1 and 2, and then they get this fairly typical facial features with, we used to call it a pixie face, but it's triangular faces. So fairly large head and then triangular chin. Radiographic features, we know wormian bones in the skull, codfish vertebra, osteopenia, generalized osteopenia, thin gracile bones. You can see, look at the fibula in this X-ray. I mean, they basically look like strings. Then they get what's called a trefoil pelvis. And that's actually something that I took years to understand what that actually means. But a trefoil is basically French for 3 leaves, and it refers to the shape of a clover leaf. You know, a 3-leaf clover. So if you think of the sign of the Boy Scouts, or that sort of like 3-leaf clover shape, that's what's meant for the trefoil pelvis. And then they get basilar imagination on the skull, of course, and coxa vera, amongst other things. These are just some X-ray features, or this is a very severe OI. We actually thought this is probably a type 2, but the patient survived. So born with multiple fractures, femur, tibia, vertebral fractures, multiple rib fractures. You can see all these little balls, just rib fractures. So that's quite severe. And then this is just some more X-ray features. And this is actually quite an interesting patient. So she came to me from, she was from rural areas. She was quite neglected. And you can see she had some intervention at some point in her life. Somebody put in a tensile there, but then there was no follow-up. And she had this severe non-union of a femur and the tibia. It was disaster. And she couldn't walk, so she walked on all 4s. And this is actually the first time I've ever seen humeral deformities in OI, because usually they don't walk on their arms, so they don't deform so much. But this particular patient actually had quite severe varus of both arms because of the all 4s walking. So just to see if you're awake, Ashley.
Yes.
Yes. So this little child presented mostly complaining of a elbow deformity that you can see there. That's what she looked like, and that's the X-rays. Do you want to hazard the diagnosis?
So I'll start looking at her face. I think there's some element of frontal bossing. Otherwise, apart from that, I don't see any other dysmorphic features. I'm not sure if her sclera are blue or not.
Look too white.
Sorry?
I don't think they look too white. But yeah, who knows? Yeah, but it's maybe.
So looking at the arm,
what deformity is that? You have an X-ray as well. So
so the arm, looking at the arm, looks like there's some element of cubitus varus on the elbow. And then looking at the
No,
X-ray.
no, you have an X-ray. Look at the X-ray, look at the arm.
Sorry?
I say you have an X-ray. Look at the X-ray and look at the arm. What's going on there?
So I'll start from distal to proximal. So distal physis. Actually, I don't see a clear physeal line. So there is abnormality of the radius and ulna, the mid shaft of the radius and ulna. So the radius and ulna are bowed abnormally, and there's a synostosis between the radius and the ulna.
Elbow?
The moving more proximally, the proximal radio-ulnar joint, the radius is dislocated. The ulnar humeral joint looks relatively normal. The radius is dislocated. So in terms of diagnosis,
Radial head dislocation and what you called synostosis of the radius and the ulna. And we've just spoken about osteogenesis imperfecta.
Yeah. So it probably is osteogenesis imperfecta with the.
Which type?
So it would be probably type. So she's got blue sclera, so it's either type 1 or type 2, and so I think the type 2 is lethal, so it's probably type 1 osteogenesis imperfecta.
Hey.
Sorry?
It's a type 5.
The type 5, the rare one with the
Yes, but I just mentioned it, and I actually read all the information there. Not going to forget this again, eh?
Yes.
No. Okay. All right, and this is just to show you how well the operation worked. So I did a radial head excision, and then it basically grew back. So this was, I think, 6 weeks post-op, and this was about 3 months post-op. So that was a waste of time. And actually, before I did the procedure, I did read up about it, and I found 2 case reports, and they were like, it doesn't really work. But I thought, I can't make it worse. But turns out you can. So don't bother trying to excise the radial heads in these kids, they just grow back. Okay. So what's the role of bisphosphonates in OI? So there's a little bit of controversy about it, although universally it is accepted that bisphosphonates should be used for patients with severe OI. So that would be your type 3s and 1s and 3s. No, 1s and 4s, 3s and 4s, sorry, 3s and 4s. And see, so I don't really, you know me, I don't really like classifications. I don't find them particularly healthy but the bad ones, the ones that break the whole time. So it increases the bone density, but it doesn't address the underlying pathology at all, because we know osteogenesis is caused by a collagen defect, and bisphosphonates increases mineralization of the bone. So you're treating a collagen problem with a mineral solution. So, it's obviously not the gold, the golden bullet perfect answer, but it's one of the few things we can do for these kids. So you should do it. It does decrease bone pain. It does decrease fracture rate, specifically vertebral fractures, not really the long bone fractures. It improves mobility, increases growth, and it does not affect fracture healing. So there's some question about whether or not it actually affects osteotomy healing, but the studies that showed this was like a little bit dubious because they didn't use low energy osteotomies and it's open osteotomies with oscillating sores burning the bone, etc. So I can't imagine that if you do a low energy, the Bastiani type of osteotomy, that the bisphosphonates will decrease your healing rates. But currently, the rule is that you should discontinue bisphosphonates up until 3 months following your osteotomies, if you're going to do them. And then again, just carrying on with that, cyclical permethrinate or lendronate is the most often used. Oral bisphosphonates are also successful, but less well tolerated, of course, because we know about all the gastrointestinal side effects of that, having to eat it on an empty stomach, etc. So it's very difficult for children. And as opposed to a daily dose, the cyclical ones are every 6 to 9 months. So it's much better. No adverse events have been reported other than your initial hypersensitivity reaction. And actually, osteonecrosis of the jaw has not been reported in children either. So it seems to be an adult issue. And then the principles of surgery for OI is correction of deformity and protection against future fractures. So intramedullary rodding is the mainstay of treatment. Plate and screw constructs are not advisable. They cause stress rises, and these patients will just fracture or deform distal to the implant. And surgery is difficult because it's small, deformed, fragile bones. You can't hold them with bone holders. They just crack. They bleed a lot because they have platelet dysfunction. And there's also a frequent need for revision of rods during growth. So even if you use the expanding rods, they often don't expand or bend or something. So these are just very difficult cases. This is just an example of a fascia Duval rod, which is the telescoping rods that we use for OI. And this guy is actually doing quite well, but he's a very mild OI. So he's probably, does he have blue sclera? No. So he must then be a type 4. But he, I mean, he had deformities and fractures, but he's relatively mild compared. And then there's just an important concept here is the management of coxa vera in OI. So this is very difficult, and I only learned about this a little bit later in my career. But they all get this coxa vera. They get stress fractures at the neck shaft junction and slow deformities. You can see the stress fracture going on there already, but there she's broken. And then I did sort of like a standard FD rod for her on the left side because I didn't know about the clever technique to address it. And then I was a little bit unhappy with the outcome, of course, because the veras just increased. And then we did so there's this technique where you actually put the FD rod in from the lateral cortex as opposed from the intramedullary space, goes in through the peripheral fossa, use K-wires to sort of act as rafters in the femoral neck, bend them down and tie them with circlage wires. So that works really well. And finally, after 2 revisions, she now has, we've treated the coxa vera. I know those wires don't look great. And all I can say is this was not an easy operation. Okay, so moving on with the soft bones, we're done with the pre-exam guys. I'm just going to ask some of the senior guys a few questions as well. Kim. You're up.
Hi, boss.
Hi, Kim. Cool. So just describe what you see here and then as a diagnosis.
So this patient has severe bowing of both femurs. I see that they've had previous surgery, so they've got bilateral medial 8 plates or guided growth. So I'm not sure what the deformity looked like beforehand, but severe bowing of both femurs. The bone quality itself looks fair, but the femur's diaphyseal, especially on the right side, looks widened. I can't see if there's any stippling or any abnormalities in the bone itself. I'm not sure. So it's more a diaphyseal bowing rather than a shepherd's crook type of deformity. It's not in keeping. So there's also tibial deformities or leg looks like there could be differences in the length of the tibia, right being slightly longer than the left. And the overall alignment of the limbs, the pelvis is not really centered over both ankles, it's more over the left side. The pelvis is also looks like an inlet view. Difficult to see the bones of the pelvis themselves, but I don't see any obvious pathology.
Just tell me, Kim, I'm not going to try and steer you in the right direction here. Why would you say this is not a shepherd's crook deformity?
The bowing is more involving the entire bone, and diaphyseal, including distally, the bones don't look normal. So I'm leaning away from a fibrous dysplasia type diagnosis, although it could still be possible.
I'd like you to lean back towards.
Okay.
Yeah. So this is a
right.
classic shepherd's crook deformity. I mean, the whole proximal femur
Okay.
is bent into basically has the neck drop angle is less than 90. It's bowed there, the proximal femur. This is where the shepherd's crook occurs.
Okay.
And the fact that she has distal abnormalities does not mean that it's not.
Okay.
And
Okay.
I think the guided growth at the knees may be swaying you a little bit because
Yeah.
it was trying to address a knee deformity, but without addressing the proximal deformities, etc. But look at the quality of the bone. Can you see a clearly defined medullary space at cortex? No.
Okay. All right.
Leaning back towards fibrous dysplasia. So if I told you that this girl at the age of 8 was a Tanner stage 5 or 6 or whatever, sexually mature.
Mm-hmm.
Mm-hmm.
So being skeletally mature.
Sexually mature. She's 8.
Sorry, I missed that.
At the age of 8, this girl is like a Tanner stage 4. So
so advanced sexual characteristics. So she would be I've forgotten the name.
Anybody from the audience want to hazard a guess and a term here? The guys that's currently at Red Cross not allowed.
Was
McEwen Albright. Yeah,
yes,
McEwen Albright.
Yes. Thank you, Ben. Thank you. Yes. So this patient is McEwen Albright syndrome. It's extremely rare, but it's absurd. This is fibrous dysplasia, guys. So you can see there's no clear distinction between the intramedullary and or the medullary space and the cortex, because there is no medullary space. If you operate on these kids, it's solid fibrous tissue or this plastic bone. It bleeds like nobody's business. There's no difference between the cortex and the medulla of the bone. It's all the same. The ground glass appearance, I don't know. I don't think any of us really know what ground glass looks like anymore. But you can see there's no clear medulla space. There's some changes over there, and there's a very definite shepherd's crook deformity. So that's why I showed this case. So Kim, what is the triad of abnormalities that you see in McEwen-Albright syndrome?
So advanced sexual maturity.
Puberty.
Precocious period. That is the word I was looking for. Sorry. It's an endocrine abnormality of the sex hormone. I can't remember if they've got skin lesions as well, like cafe au lait spots. And then the bowing or the shepherd's crook deformity.
Okay, so in big words, Kim, it is polyostotic fibrous dysplasia, cafe au lait spots, which is the coast of Maine, is the irregular one. Like again, I hate this whole coast of Maine, coast of California nonsense, because I mean, what normal South Africa knows what the map of the USA looks like to this extent, but it's irregular spots as opposed to neurofibromatosis that has smooth edges, and then they get endocrine abnormalities. So always precocious puberty, and then hypothyroidism is the other one they frequently get.
Hypothyroidism.
This talk is going to be full of pink canaries, guys. You better keep ortho bullets handy. Okay, so the treatment for these guys is bisphosphonates for the severe deformity. It helps. And then deformity correction using similar principles as for osteogenesis imperfecta. But like I said, surgery is complicated by excessive bleeding and the soft bone. And this is just another example. And this patient is actually en route to Red Cross at the moment. She's about 13 now. this was quite a while ago. She presented like this with clear stress fracture and early coxa vara on the right side. So I did like a little cheap operation here with a 6 or 5-hole DCP actually. That was clearly underpowered to correct the deformity, and she's bended away from the plate again. So this was then revised to a slightly more robust implant, but I'm not following my own rules here, you see. So I used the plate as opposed to an intramedullary device. So she was booked to have the coxa vara addressed on the left, and now she's fractured there. She's got a subtrochanteric fracture there, so she's on her way to us to come and fix her again. But yeah, no, yes?
I know this patient. She's given me a lot of headaches.
Can you remember her name?
I know her. I'm not going to say it. She's given me a lot of headaches. Good luck.
Thank you. Her mom has my phone number, so it's also a little bit dangerous. Okay, so this is a little bit off the soft bone, but the principles are not dissimilar. Peter Botha.
Hi, Anria.
Hi.
So what I'm presenting with multiple images, top left of skeletally, I would say, immature patients with obvious coxa vara deformities of both proximal femurs. Appears like an inlet view with, I would say, increased bone density or generalized increased bone density, particularly like osteopetrosis kind of picture. Going to the bottom views is just a frog leg lateral, on the top right is showing you the humerus. I mean, all these views showing increased generalized increased bone density.
That's the only thing I wanted to correct you on, is that's not really an inlet view.
Okay.
That's like the inlet view was, you see the whole round.
Yes, sorry.
No, that's not that. But yes, coxa vara severe increased bone density, most likely osteopetrosis. In fact, this is osteopetrosis, so that was an easy one. So the osteopetrosis, sorry, I didn't mean that as insulting. Failure of osteoclast function. So basically the osteoclasts don't work, so you don't get the usual bone turnover with plastic and classic function, and they just get this increased bone density. So loss of medullary space. Then as a result of that, because we know we get hematopoiesis in really only in our spongy bones, so pelvis, vertebrae, etc. So as a result of the sclerosis of those bones, there's no hematopoiesis there. So they get associated anemias, and then hepatosplenomegaly, again, secondary to that. And they're quite prone to bone infections, and their orthopedic problems is frequent fractures, coxa vara, and then early onset OA of the hips and knees. But you can make them better. You should address their deformities. It does actually improve their lives. Okay, so that's the metabolic conditions done. So the skeletal dysplasia, so these are all the forms of short stature and dwarfism, broad group of disorders. Dwarfism is defined as a height that is 2 standard deviations below the mean for the population. And the orthopedic role in these conditions is to prevent future limitations, correct deformities, and then prevent and treat pain. Achondroplasia is by far the most common skeletal dysplasia, and is caused by an abnormality of eidocranial ossification. And that is why the intramembranous bones, so the bones that ossify via intramembranous ossification, such as the skull and the ribs and the pelvis, is actually of a normal size, and that's why they get a disproportionate dwarfism with short limbs. So 1 in 25,000, fully penetrant autosomal dominant, but about 80% are spontaneous mutations. Their clinical features is rhizomelic dwarfism, so short limbs. Rhizo is Greek for root, so the roots of the limbs are short. Trident hands, that's that story. Large head, mandibular protrusion, frontal bossy, hyperplastic midface. And then their typical deformities is genioverum and internal tibial torsion. But their main orthopedic concerns are really in the spine. So they get the thoracolumbar kyphosis and lumbar hyperlordosis. But more importantly, they're extremely prone, as almost all of them get spinal stenosis. So they can also get foramen magnus stenosis, which they get in infancy. Then the kyphosis, which usually doesn't require any treatment, but then because of the short pedicles in the spine, they get severe spinal stenosis, and most of them require some intervention for that. So the main issue with achondroplastics, I suppose, is the fact that they're so short. And even though people may consider it to be merely a functional problem, it actually does severely affect their ability to participate in normal activities of daily living. For instance, going to the shop. I mean, if your head is below the level of the countertop, that certainly makes life difficult, doesn't it? Using public bathrooms, you can't get onto the toilet, you can't reach the door, driving, things like that. So lengthening for these kids are not actually purely cosmetic. I think it's quite functional, actually. I don't personally have any experience with it because I don't see the achondroplastics at Red Cross, but in my fellowship we did do a few, and it really improves the quality of life. And unfortunately, it is fraught with complications, as all lengthenings are. And if you do consider it, you should delay until adolescence, when the patients can contribute a little bit more. And this is pictures I got from the articles. I mean, I don't have my own patients to show you, but just look at that difference. And yes, I mean, she's got terrible scars over her legs, but she's so happy that she doesn't care. She just wears a short skirt. She has long legs now. So they usually, this group did humerus, femur, and tibia. And obviously more than one episode of lengthening, as you can see, there's incremental height gain. But I do think that this is actually a worthwhile endeavor for these patients. Okay. Peter Venter. Just describe what you see here if you want to. I'll show you the x-rays before I'm going to ask you to try and make a diagnosis.
So, hi, Anria. It's a frontal and back photo of what looks like a pre-adolescent child trying to stand upright.
Yeah, so he's in his teens. He's 14.
Okay. So, he's trying to stand upright as much as possible. Clearly, you can see it from the back. You can see it has a right-sided flank crease, which may indicate scoliosis. Looking at his pelvis, you can see that the pelvis is clearly tilted while he's standing, with and it's anteriorly tilted as well. So his pelvic obliquity. His left leg seems to, because of compensatory for the pelvic obliquity, he is flexing it, and it does seem to have an element of genovalgum as well. With his his torso and upper limbs being in proportion lengthwise what you'd expect for his age, with his lower limbs I would think is shorter, but that could just be because of the picture, that fact that his pelvis being tilted.
Would you say this is a proportionate or a disproportionate dwarfism?
Disproportionate.
Yeah, all right. Would you like to see some x-rays?
Yes, please. Okay. So multiple images, left side of femurs and tibias and knees, pelvis, and then including spine. You can barely see the epiphyses, abnormal physes as well, with it looks like coxavara on both. So no, the femurs being bowed more than the tibias. His spine, his pelvis. He's got a very if you look at his ilium, his ilias are wider than you, and with his ischium and pubic bones being narrower. I don't know if I'm explaining that well, but sorry, I just want to move this. With on the lateral of his sagittal view of his lumbar spine, he has very flattened vertebrae with short pedicles, not really a marked abnormality of lordosis. And in looking at that, he doesn't really have a scoliosis, so the problem must be below the pelvis.
Yeah, from that leg. Okay, so do you want to try and make a diagnosis, or?
You. No,
abnormalities of the epiphyses and of the vertebra.
Epiphyses and vertebrae. No, I don't have a specific one, sorry.
Okay, that's fine. So this is spondyloepiphyseal dysplasia.
Okay.
Yeah.
Easy.
Yeah. Also very uncommon, like all the conditions we're going to discuss tonight. So spondyloepiphyseal dysplasia, you get both the congenital and the tarda form. So the congenital is more severe, the tarda is milder and only really presents later in life. It's rare. Causes a proportionate dwarfism. So I'm always a little bit confused about that, but I think the disproportionate dwarfs are the ones with the like very short limbs and the normal trunks.
So it's the same, on the same limb, the proportion is different.
Yeah, so I think if this guy's leg was straight, he would look more proportionate. You know, so if you compare him to the achondroplastics, like his head isn't so disproportionately large compared to his trunk and his arms and everything like that. I mean, if you just look at the top half, that doesn't look too bad. So he just fails in the lower limb segment. Anyway, it's classified as a proportionate dwarfism. And the orthopedic issues are upper C-spine instability, scoliosis, coxa-vara, and other deformities, as like with all the other deformities. So Bayanda, I'm going to treat you to this one because you should know, you should remember this girl.
I know her very well.
Good. So you can just describe and then tell us what the diagnosis is.
So this is a picture of an adolescent. She has dysmorphic
11 or 12 year, eh?
Oh, is she 12 now?
I don't know, I can't remember, but I thought she was about 11 or 12 at this stage. Was she older? Doesn't matter.
Okay, so this is an adolescent child. She has dysmorphic features on her face. She also has, looking at her extremities and the hands and the feet, she has actually, sorry.
How many knuckles do you see there? How many phalanges?
Phalanges 1, 2, 3. She's got five fingers. They all are sort of similar length, but they're short. And her toes, just the big toe is the normal, well, the big toe is longer than the rest of her toes. The rest of the other toes are all the same length. She also has, she is short for, she's short statured, and that's all that I can see in these images. And she's sitting down and not standing.
Yeah, she's sitting.
Okay, so I am presented with X-ray images. The first one is of a hip fib with a healing tibia fracture. The fibula is still intact. Basically, on all the end in the femur, she also has a plated femur, and she is also the X-ray of a forearm with a hand. The striking feature is that there is you can't see the difference between the cortex and the medulla. It's quite, I don't want to say sclerotic. It's white. And ankles, knees all look normal. And going to the forearm, in the forearm, it looks like the radius is a little bit bowed, but the ulnar looks normal. I'm not sure if this is a Paget's or
Patient.
I remember her, but I can't remember her diagnosis.
Who gets Paget's disease? Old people.
Old people, sorry.
Old people get Paget's disease. Count the phalanges. Most of us have 3 phalanges per finger. She only has 2. You see?
Oh, I didn't look at the fingers, sorry. So, phalanges. 1.
Oh.
So that's
Okay, so
1.
that's the one thing. And then this is another boy. I actually saw him in Malawi. Same type of face. And can you see the similarity between that face and that face?
Yes, I can. Yeah.
Oh, sweet, né? Same hands, same bones. Okay, so with stress fractures and so on. So this is pycnodysplasia. We're coming back now, Bayanda.
Yes, it is. I'm sorry. I completely forgot the name. Okay.
It's again very rare, but it is a sclerotic bone disease, and it's the same with osteopetrosis. It has the same problem. So okay, so they're dwarfs though. So the osteopetrosis aren't as short usually. They're short, but not that short. They get osteosclerosis and fragility fractures, same as the osteopetrosis patients. It's an autosomal recessive disease, and then they get acro-osteolysis. So that's the term we use for the stubby fingers and toes where the distal phalanx is basically gone. So this is characteristic. You see this, you see that face, you see those hands. That's pycnodysplasia. And the management is basically like it would be for any other type of disease. You treat their fractures. There's no medical management. You basically just maintain correct deformities and treat their fractures as they go along. Okay, so this one is just for fun. So I've only seen this once in my life, and I took a video, and he wasn't actually even my patient. He was one of my patient's siblings, and his mother just brought him along for entertainment value. So look at what he can do. That's quite unusual. And then this is his party trick. It's impressive, right? So if I told you, so I'm going to see if there's anybody that wants to guess this one or try and know this one. If I told you he had delayed closure of his cranial sutures and his fontanelles, and he's a little bit short, like he's not dwarf, but he's fairly short for his age.
Eidocranial dysplasia.
Yay, who was that? Peter.
Me, Peter. But I watch Stranger Things, and he has it.
Well done. Yeah, so this is very rare, but it's impressive, right? Anyway, so he's got cleidocranial dysplasia. It's a rare autosomal dominant disease, and it's caused by abnormality of intramembranous ossification. So remember we said achondroplasia is inchondral ossification. So this is now intramembranous ossification. So all your bones that developed by intramembranous ossification are affected. So that's why it's the skull, it's the clavicles that are often absent. So that guy has no clavicle. And then the proportionate dwarfism. And I'm not sure about the coxavera, but they also get delayed ossification of the pubic symphysis and so forth. So nothing special to do here, really. I mean, there's no reconstruction for the clavicles indicated or anything like that. It's just fun to know about. Okay. This one's a bit tricky, and I also missed the diagnosis, so I'll just tell you guys about him, unless there's somebody that desperately wants to hazard a guess.
And try to guess.
Okay, Abbas. Omar, sorry. Ooh, but your team.
Yes, Andrea, there's a picture, clinical picture of a short-statured young boy, which looks
14,
like a
so he's
disproportionate.
14 years old.
How old?
14, 1-4.
Okay. Well, adolescent, short stature, also disproportionate dwarfism with a large head compared to the torso and the lower limb. I can see he's trying to wave to us. So the obvious thing I saw that his hand is there's a abnormal formation of his fingers. They look a bit wide and short. Then he also has what looks like a valgus deformity on the left side. What else can I see? His elbow is flexed. Yeah, I don't see anything else on this picture. So other than dwarfism, short hands, and gender valgum on the left side.
He also has a club foot. Sorry, you can't really see it. I don't have naked pictures of him, but he also has a club foot on the left.
Club foot, yeah. So would this be, I'm not sure, I'll guess as a mucopolysaccharidosis or epiphyseal dysplasias, multiple?
No. Peter Guetta?
Okay.
Marcelino is diastrophic dysplasia.
Yes, it's cheating because you guys know the patients. Yeah, this is Marcelino Jamie. He's a dystrophic dwarf. So like I said, I also didn't believe the diagnosis when I saw it, because the classic feature of a dystrophic dwarfism is the hitchhiker's thumb, which he doesn't really have. Well, which he doesn't have at all, actually. But I think the geneticist sort of looked at his picture and decided that's the syndrome that he fits in the best because of the knee contraction and the club foot and the disproportionate dwarfism, like you said. But the dystrophic dwarfs are also meant to have like severe cervical kyphosis and scoliosis and so on, which he doesn't have. So yeah, so that was dystrophic dwarfism, short-limbed. So like you said, it was disproportionate, well done. But they're also meant to have funny ear scoliosis, the thumb, and then the hip and knee contractures and the skew feet or the club foot. And this is just, I got off the internet, sorry. But that's the hitchhiker's thumb is just like a thumb that's either stuck like that or even worse. So it's like almost vertical or parallel to the wrist. Okay. And briefly, okay, so we're moving away from the skeletal dysplasias or from the dwarfisms now. Okay, so multiple hereditary exostosis or osteochondromas, MHE. Let's briefly talk about that. So that has to be distinguished from a solitary exostosis. A solitary exostosis is a completely benign condition. Nobody really worries about it. It causes cosmetic and sometimes mechanical problems, but the rate of conversion to malignancy is so low as to be negligible. MHE is caused by mutations of chromosome 8 and 11, etc. It's autosomal dominant, so you obviously see this in families. And the clinical features would be short stature, so not quite dwarfism, but the lower end of normal. Widened metaphyses with sort of like a stocky appearance, and then the clinically obvious exostosis around the metaphysis. And the way I understand it, and I could be wrong, is it's a concept of metaphyseal steal, so as in stealing from somebody, is that if you have these large exostosis growing around all your growth plates, that must take away some of the growth potential from the actual growth plate and thereby lead to shortening of the limbs. For instance, in the arm, you'll often see if there's a large exostosis in the ulna would be disproportionately short. And the only way that I can explain that, because it's not tethering or anything else, is this concept of the osteochondroma stealing the growth from the growth plate. That's just my theory. Anyway, so this is what the X-rays would look like. The exostoses grow away from the growth plate. So they always have the sort of the apex of the deformity in the opposite direction of the actual physis. And they can cause deformities due to irregular growth or unbalanced growth. And then, like I said, it can also cause compression and irritation of other structures, such as the peroneal nerve or the ITB, depending on the location of the osteochondroma. It can also lead to limb inequality for the same reason. So malignant transformation is only 5% after skeletal maturity, and it is characterized by rapid growth of the osteochondroma, and then on MRI, a cartilage cap of bigger than 2 centimeters in adults. The treatment is mostly observation, excision of symptomatic lesions, correction of deformity, which you can do with guided growth or osteotomies. And then with the spinal osteochondromas, if it causes symptoms of radiculopathy or spinal stenosis, then it can be complicated as well. Okay, so before, let's see. Okay, I might have shown that too much now. Okay.
Andrea, sorry, do
Yeah.
you mind if I just ask a question? In terms of MHE, in terms of the follow-up, from my understanding, it's a little bit difficult to sort of figure out how often to follow them up, you know, before they reach skeletal maturity. So
I'd follow them up annually, just to check. It kind of depends on the patient themselves. So if you've got these very sort of like aware and educated people, then they can monitor it themselves. And then you can say, listen, come back to me if there's something that's bothering you or if something's getting bigger, etc. But otherwise, I'd see them annually and monitor them for symptoms and pain and growth.
Okay, thanks. And then after they reach skeletal maturity, I think my understanding is an indicator of malignant transformation is after skeletal maturity to sort of have sort of resurgent pain or discomfort afterwards.
Yeah, exactly. So they should stop growing with the person. So then if they continue growing or they suddenly start growing again, then that's indicative, and also pain. But I mean, I don't think it will be practical to follow patients up regularly to check for that if the incidence of malignant transformation is so low. So I think patient education is probably more important here, and informing them that if there's a change, an increase in size or pain, then they should present. The thing is, achondroplasia is also a relatively low. It's not a very aggressive tumor, so the odds of them presenting to you with like end-stage metastatic disease is extremely low. So it's kind of a low risk malignancy, if I can phrase it like that. So I wouldn't recommend regular follow-up after skeletal maturity.
Okay, thank you.
So look at this guy and look at this guy. So they both have, they're part of the same group of syndromes, but they just have different variants of that condition. So Omar, I'm going to give you another chance.
Yeah, sure.
Yeah.
Yes. Hello, can you hear me?
Yeah, I can hear you.
Yes, yeah. So again, another short stitcher. Also, probably this looks like more proportionate form of dwarfism. So when I look at this, starting with the face, I don't see any obvious severe dysmorphic features that I'm worried about. The neck is quite short, so the short neck, large chest, to the body ratio. Also, in terms of his upper limb, I can see a deformity of his distal radius, and then his hands are quite big, short, similar to his feet as well. Not able to comment on the alignment of the lower limb, but his left leg looks to be in a bit of a valgus deformity. Then there's another
You can't
X-ray.
really see very much, but you can see his face and you can see his legs.
Yeah, so it's 14-year-old bilateral lower limb X-rays showing a genivalgum. Starting with the clinical phase of this child, I would like to say he has a bit of syndromic face. His body stature looks proportionate, short proportionate stature. And looking into the X-ray, he has, as obviously as mentioned, he has a bilateral lower limb deformities with a genivalgum. The physis looks closed. Going to the pelvis, there's a trefoil-shaped pelvis.
It does actually.
Then, yeah, the proximal femurs look in normal alignment and angles. Yes, so this is mucopolysaccharidosis that we saw last time.
Well done. So both these patients have a form of mucopolysaccharidosis. This guy has Anria syndrome, which is MPS type 4. And this one has a very mild variant of MPS type 1, which is Hurler syndrome. This is another Anria. Okay, so MPS is a lysosomal storage disorder, and you get accumulation of sulfated glycosaminoglycans in the tissues. You can remember that, I'd be very impressed. It's also relatively rare, but it's a group of deformities and of conditions, and they have a relentless course if not treated. So the four main types to try and remember is Hurler's, Hunter's, Sanfilippo, and Anria's. Their clinical features is the first thing is the coarse facial features or gargoylism. So I think he's probably, of the four I showed you, he's got the most sort of like coarse facial features as all of them. But try and see the similarities between that face and that face and that face. It's just an appearance of like, it's like the coarse nose, coarse eyebrows, coarse feet, ears, everything. Short stature, joint contractions and deformity, scoliosis, mental retardation, and all of them except type 4. And actually this type 1 guy, and that's why I didn't believe the diagnosis, because they said he's a type 1, but he's bright as a button. And then when I did some reading, it turns out there is a very mild variant of the Hunter's Hurler syndrome, which doesn't affect the intellect. So that must be what he has. Yeah, covered, yeah. Okay, and then again, they get C1, C2 instability, angular deformity of the lower limbs, hip subluxation, dysplasia, degeneration, and often scoliosis as well. So this is just an example of what the X-rays look like in the spine. This is Anria syndrome. He's got this disorganized appearance of his vertebral bodies and spine, and he had C1, C2 instability with spinal stenosis, and you can see cord signal changes up there. He had a fusion, and then it's the same patient. I treated these. Obviously, my operation was a lot less impressive, but the results were quite good. So within 12 months, he corrected his gene variant completely with guided growth. But then they also developed hip subluxation. So you can see this X-ray is the same patient. His hips are starting to sublux because of the valgus. So I did like mild, so various osteotomies for them, but also reactivated these guided growth plates to correct the overall varus or valgus of the lower limbs. So this, for those of you who don't know, we call this sleeper plates. So if you have a patient who's got an underlying problems such as MPS or something where you think the deformity is prone to recur, then you just take out the metaphysical screw of your guided growth device, and then that makes your reactivation of the plate, if you could call it like that, a lot easier. You just put in one screw. It's just a concept. Okay, so the diagnosis here should be fairly obvious. Francis, will you have a look? And then I need you to tell me what the orthopedic concerns are in these patients.
Okay, can you hear me all right?
Yeah.
Okay, so it looks like an adolescent girl, frontal and posterior pictures. She's showing her legs on the frontal image. It looks a little bit like her right knee is a little bit sort of externally rotated. I can't see her feet to know which way her feet are orientated though. The left knee has a scar over it. Otherwise, she seems quite tall. Face is a bit sort of rounded, chubby cheeks, but not otherwise obviously what's the word I'm looking for? Dysmorphic.
No, you failed. Next one.
Okay.
Sorry, Francis. No, she's clearly dysmorphic.
Okay.
Bianda. Bianda, are you still with us?
Yes, I am.
Yeah.
I didn't know if it's okay to say, but she looks like she's got cerebral palsy.
Oh, no.
Down syndrome.
Yes, man.
Down syndrome.
Nice.
Is it? I can't see the flat. I can't see the flattened nasal ridge.
Look at that face. That's Downs.
Is that a Downsy?
That's a Downsy. Yes. Yeah. So sorry.
No, she's not like obese.
Can't say Downsy.
Okay, sorry. Sorry, Peter.
You can. It's a safe space. It's a safe space.
Okay.
Yes, but she has Down syndrome. Okay. So now, Bayanda, Bayanda, will you tell me what are the orthopedic concerns in a patient with Down syndrome?
Okay, from head to toe, C1, C2, subluxation. And then there's the heart, nothing for us in the heart.
We do need it to pump the capsule, but
yes, okay, going down, nothing in the shoulders, clavicle, and going to the hips, Sufis, the hips, the pelvis, nothing in the pelvis, in the knees, patellar subluxation or dislocation, going down, nothing in the feet that I know of. And then in the hands, just the simian crease, usually are hyperlax, they have hypothyroidism. Other than the spine and the hips, Anria, and the knees and the patellar dislocation, I don't have anything else for orthopedics.
Well, that's enough, isn't it? So they have, like you said, C1, C2 subluxation. They're prone to scoliosis. They're prone to dysplasia.
Dysplasia. Okay.
Yeah, it's not such a big thing. They are prone to SUFI. This is an example of a patient with Down syndrome with SUFI. That's another example of a patient with Down syndrome with C1, C2 instability. They get genovalgal and patellar dislocations and then flat foot. So basically all the hyperlaxity related problems. Then, so those ones you treat on their own merit, basically. So it's nothing different for the Downs. It's just important to know about their anesthetic considerations, which is C-spine instability, like, obstructive sleep apnea, especially if they're obese, which they often are. And then the cardiac abnormalities in like almost all of them have some sort of cardiac problem, and then hypothyroidism. So this is not somebody you're also going to book on the list for Maitland unless they worked up quite nicely. I just want to show you this case of a chronic patellar dislocation in Blount's disease. So, Down syndrome. So there you can see there's the patella sitting lateral to the knee, and you're also getting quite a torsional view of the femur. I think the femur is like internally rotated relative to the externally, yeah, rotated. I think it's internally rotated relative to the tibias. There's gena valga, and then there's also that inferior patellar pole stress fracture on the right. And what's next? So this is just a video. So this is a child. This is not the one I showed you earlier. Is another one. So this is after I fixed the right leg, but now the left leg has the same problem. And this is just so that you can see the difference. So this is her trying to extend the left knee. She's trying very hard. There's a right knee. That's working well. Left knee again. No. Anyway, so it works well, but it's quite difficult. You have to like do osteotomies and big lateral releases and so on. Okay, Benjamin, what's the diagnosis and what are the orthopedic concerns?
Hello, boss. So she seems to have a wide arm span, spindly, lanky limbs. I think it's Marfan's, also from the face, I think. Orthopedic considerations, hyperlaxity in the spine. I think they're prone to dural ectasia.
Yeah. No, wait. Yes. Yeah.
Yes, and then hyperlaxity. So they also have the hyperlax. So in the hips, I think acetabular protrusio and dysplasia. And then patellar dislocations, recurrent patellar dislocations. In the foot, I think flat feet as well.
And then what you can actually see in this X-ray is scoliosis. I know.
Oh, scoliosis. Sorry. Yeah.
Doesn't have the most revealing top on, but you can see her shoulder heights at different heights. There you can see that sort of like kyphotic deformity over there. And then the other clue is the glasses. So you know they all have like they've got lens problems. So Marfan's autosomal dominant mutation in the fibrillin gene. So unlike the other ones, it's not collagen, it's fibrillin. And that maintains the mechanical properties of soft tissues to cyclical stress. So the musculoskeletal features we have here is pectus excavatum or carinate and scoliosis, arachnodactyly. This big word basically is that when we talk about the fact that their arm spans more than their height, that is dolichostenomelia. Then they get protrusio and they get ankle valgus. And then the other organ systems, and this is just, of course, if you're going to be treating these patients, you want to book surgery for them, you need to know about that. So the lens, the harsh palate, aortic dissection, dilatation, and regurg, hernias, and spontaneous pneumothoraces. So this is the same patient, and she's just illustrating the clinical features of arachnodactyly. So it is very much just sort of like a impression when you look at the hand. But they should be able to do this. So if you encircle your wrist, is to actually have overlap of the distal phalanges of your thumb and your index finger. So that's a feature of arachnodactyly. And then the other one is if you make a fist like that, is to have your thumb protrude past the ulnar border of your hand. So those are the two clinically or diagnostic features of arachnodactyly, just to make it a little bit more scientific. And this is the same patient, so you can see she's got protrusio acetabular. Benjamin, just be careful when you say things. You can't have acetabular dysplasia and protrusio at the same time. They're the opposite things. So
Okay.
So just be careful. I know you were just like throwing out words there, but don't throw out opposite words. Okay. And then she had quite nasty foot deformity. So she had ankle valgus, but hindfoot varus, and it was a bit of a mess. Then the management of the scoliosis, because I suppose that's the worst part of it, is it's similar to adolescent idiopathic scoliosis, but bracing is a lot less effective and a much higher rate of surgical complications. So infections, instrumentation failure, dural tears, curve decompensation, and cardiovascular death, as you can imagine. And then just while we're on the topic, just briefly, Ehlers-Danlos syndrome. So this boy's feet it's not actually Ehlers-Danlos. He had an unspecified connective tissue disorder, but it's kind of part of the whole Ehlers-Danlos group. And it's caused by a variety of mutations in the collagen-forming genes. The orthopedic concerns, as usual, scoliosis, joint instability, and foot deformity. And the key thing here is the poor wound healing. So I burned my fingers terribly with this patient. I did a massive foot and ankle operation for him, correcting his ankle valgus, his hind foot valgus, and his forefoot, and everything in one go. And his foot nearly fell off. He basically had wound breakdown and the process of all his incisions. I had to remove all the hardware. He needed plastic surgery intervention, etc. It was a disaster. So that's just something to think of when you are confronted with a patient with a collagen abnormality, is that they don't heal very well. So less is more. Okay, Mohammed.
Yes, boss.
Yes. Okay, just tell me what you see.
So this is a clinical picture of the girl. What I can see obvious here, starting from the top, go down, I can't see any dysmorphic feature in her face. Neck look relatively normal. The shoulder, maybe there is some asymmetry, so the left shoulder may be slightly higher than the right. And the other obvious, there is some skin changes. What do you call capillary spot, probably. And also on the right, not the right, left flank, there's skin increased, like what do you call? When you have scoliosis deformity.
What do you think the diagnosis is?
Oh well, I mean, definitely when you have a capillary spot with the scoliosis, it's neurofibromatosis, yeah.
So just before we carry on, what are the orthopedic concerns in neurofibromatosis type 1?
Orthopedics, the main issue is that they do have dystrophic scoliosis.
Mm-hmm.
And the other problem is what you call the congenital pseudarthrosis. There's always problem with the bone healing, or there's a big issue, especially if you do fusion. So there's a risk of pseudarthrosis, which is the main issue. As far as
don't have to go into the details of that right now. And then the other thing which they get, and this is an example of that. So this girl has a very large.
Sorry. Okay. Do you want me to mention that? Sorry, I was focusing only on the scoliosis, and do you want me to mention the other manifestation as well? Right?
No, not all the orthopedic ones. So it says scoliosis, CPT, and what you see here.
Hypertrophy as well.
She has a flexiform neurofibroma of the thigh, yeah.
As well.
So that leads to massively increased growth, and they get limb length inequality as a result of it. So this child, she actually has quite a poor prognosis. So she's got a very large intra-abdominal, intrapelvic flexiform neurofibroma that's leading to this scoliosis. But in addition, it extends down the leg. So she's got this leg length discrepancy and all of that. Not really a scoliosis, but yeah, that's NF. So it's the most common single gene disorder in the world ever. 1 in 3,000 live births. So the diagnostic criteria, as we know, but it's always good to look out for it again. Mohammed, 6 cappuccino spots. It has to be more, not Mohammed, sorry, Omar.
Cappuccino spots.
Yeah, cappuccino spots. More than 5 millimeters in children, more than 50 millimeters in adults. 2 neurofibromas, or 1 plexiform. Axillary inguinal freckling, optic glioma/nodules, and then your distinctive osseous lesions, which is CPT or scoliosis, or a first-degree relative lift neurofibromatosis type 1. And here we're just going through that again. So scoliosis, repenciling, it's not really orthopedic, sorry, CPT, overgrowth, and then pseudoarthrosis of the radius and ulna is extremely rare. I've never seen that. And then the difficulty, as Mohammed alluded to, is achieving union in CPT. So the hematoma, which is the abnormal pathological periosteum, expresses rankle, same as in scoliosis. So we know already what that does. It activates the osteoclasts. So you can't really, very difficult to achieve union in these patients. So the principles is alignment and stability. So both the tibia and the fibula needs to be fixed. Wide excision of the tumor, hematoma, the periosteum, bone graft, periosteal graft, and bisphosphonates, and then plus minus BMP, but we don't use that. And then you have to use an IM rod and a circular frame to achieve the union. And sure, guys, we're running late, so I'm just going to slowly go, or not quickly go, not slowly, quickly go through these x-rays. This is just one of my patients. I've shown my registrars recently, presented with this fracture with a multiplane deformity. First attempt at fusion failed. Second attempt at fusion failed. Now I'm going smart enough, Lizarov and a rod failed, and then in the end, we did this Bailey cross union thing. So you can see what we did there. We fixed the fibula, that's key, and then got all this cancellous graft in between the tibia and the fibula to try and get a union of both bones, and that seems to have worked. So her rod's not expanding. It's quite a complicated thing, and she's currently undergoing lengthening, but the key is just to get union. Rimon, quickly, what do you see here and what's the diagnosis?
Hi, Andrea. So it's clinical pictures of a pre-adolescent boy. On the left, he's got wide set eyes. What else do I see? On the right picture, he's got a elevated left shoulder and prominent scapula. I'm not quite sure what the diagnosis is. Yeah.
But can you think of just that elevated left shoulder, or no? Okay, that never mind. Ashley.
Hi. So I think he's got some facial abnormalities. There's some frontal bossing. There's an absence of his philtrum, sort of some abnormality of his dentition also, and then the abnormality of the scapula. So I think the overall diagnosis, possibly fetal alcohol syndrome, and then the subsequent diagnosis of the neck abnormality. Sorry, the name of the syndrome escapes me, but essentially it's when you have the artificial abnormal connection between the scapula and the cervical vertebra. So there's an artificial bony bridge between the Sprengel. Sorry, yeah, that's what he's got. I think so. I think it's fetal alcohol syndrome with
shoulder. But there's another thing here which you guys both missed. So he has a low set hairline and a short webbed neck. I'm looking for the word.
Turner.
No.
Klippel-Feil.
Yes, well done. Klippel-Feil, that's right. Okay, so Klippel-Feil syndrome is a triad of a short neck, a low posterior neckline, and limitation of cervical range of motion. And it's basically congenital fusion of at least two vertebrae, and it is very commonly associated with a Sprengel shoulder, although a Sprengel shoulder can exist in isolation as well. So both these boys have both Klippel-Feil and the Sprengel, and this called just as Klippel-Feil. So 60% of them will also have scoliosis, 20-30% Sprengel, cervical ribs, rib anomalies, torticollis, webbed neck, facial asymmetry because of the torticollis. There's a very strong association with fetal alcohol syndrome and Klippel-Feil. So this is obviously in our environment where we unfortunately have a bit of an epidemic of fetal alcohol syndrome. So I'm not sure in the West or in the developed world or Scandinavia whether there's also this association, but those people also drink a lot, so quite possibly. But we can look up. But in our setting, I can assure you that that's quite common. So the clipper file principles of management is stable. You have to decide whether it's stable or not. If it's asymptomatic, just leave it alone. You can't undo the cervical fusions. If there's deformity progression, instability, or myelopathy, then you have to fix the spine. And these are the kids, if you do diagnose them, tell them they're not allowed to participate in contact sports because they, you can always imagine being a scrum half or something with this situation and you fracture your long lever in your neck and that will be the end. And the spinal shoulder, I know it says their surgery is significant cosmetic deformity or decreased range of motion, but I've got a relatively low threshold to operate on them. It's not such a difficult procedure. They actually do extremely well. Very grateful if you could take the scapula out of their neck because it is, in fact, a terrible cosmetic deformity. Okay, guys, we're nearly done. I see I'm slide 97 of 102. Peter.
Yes.
Yes. So she looks a little bit bolshy there. She's actually quite. But just look at the patient, look at the hands as well, and then that situation, and then tell me what you think her diagnosis is.
Okay. Well, she obviously has deformities in both the upper and lower limbs. It's accentuated by walking with severe recurvatum of the knees, the posturing of the hands, the wrists, with pelvic tilting, but to tie it all together, I have no idea specifically.
Okay, so if I told you she had stiff joints, and the typical deformities of the upper limbs is extension with wrist flexion and internal rotation, but both sides.
Arthrogryposis.
Yes, well done. So she's got arthrogryposis. So this is probably one of the worst cases I've ever seen. It's just she's had no surgery at this point. She's 17 years old, and she was basically going off her feet because of a severe knee pain. And yeah, I mean, I offered her quite invasive solutions to her problem because the thing is she can't sit. Well, she can sit, but she can't flex her knees at all. That's her maximum flexion that you see there, which is negative. So, I mean, if she travels by bus, she's from Eastern Cape. If she goes home by the bus, then she needs to book 2 seats and that kind of thing. So I offered her surgery to get knee flexion, but then she was too worried that she wouldn't be able to walk anymore. So she rejected my offer. Okay, so that's arthrogryposis, also known as amyoplasia or arthrogryposis multiplex congenita. The etiology is uncertain. We don't really know. There's lots of theories, and I think there's probably a variety of insults that can lead to the clinical picture. So maternal antibodies to your acetylcholine receptors, decreased Anria Horn cells in the spinal cord, fibrous, and that leads to fibrous ankylosis of the joints and fatty changes in the muscles. So if you do an MRI of these kids' muscles, there's nothing. There's basically, it's like you would see with a denervated muscle. So fibrofatty changes with no active or functional muscle tissue. And one of the key clinical or diagnostic features in these kids is the lack of their creases around their joints. So they get smooth little finger joints and ankles and knees and so on because in utero they didn't move. So there's just no flexion creases. So it can affect either the whole body or only the lower limbs, which would be distal arthrogryposis, basically joint contractures, typically extensions of the knees and the elbows, and fixed and pronated wrists with a clubfoot. They can also get hip dislocations. It's quite common. Like I said, no flexion creases, and they're usually of normal or actually above average intelligence. This is slightly anecdotal, but that's just been my experience. These kids are very bright. So when you manage them, you have to be very careful consideration of the functional impact. The upper limbs are best left alone. These children adapt. And because the joints are stiff and they aren't muscles, if they can use their hand in the position that they were born with, leave it alone. You cannot make them better. The scoliosis is usually resistant to bracing. Natural history is progression, so they probably need surgery. Leave the hips alone. Yeah, putting them back isn't going to make them any better. The knee contractures tend to recur if you treat them. So again, just leave it alone. And the club feet, they're very stiff and resistant to concerti management. So we usually do PMRs for those ones just to get insurable feet. But again, if you have a child that's, for instance, crawling, then a stiff plantigrade foot is less functional than a stiff club foot for crawling, for instance. So it's very important to consider, you know, what their functional status is before you start intervening, because they're incredibly adaptive. This child came to see me because of his hands, and his parents wanted to know if I could make him better. But he was already writing like at the age of 4 with his deformed little hands, and I was just like, no way, I'm not going anywhere. Anyway, it's the end, guys. This is my last slide. So just to remind us that the syndrome means a group of symptoms which consistently occur together, or a condition characterized by a set of associated symptoms. So the key is pattern recognition, and obviously the more you see it, the more you'll be able to recognize it. But it is very rewarding field of orthopedics, especially obviously for me. So recognize the patterns, be aware of all the associated non-orthopedic conditions, and that, because that's going to mess up your outcome, your anesthetic. You don't want because you didn't read your ortho bullets, that the anesthetist cancels the case because there's some anesthetic thing that you didn't think about. Treat each problem on its own merit, and remember that your role is to improve their function and prevent future disability, correct deformity, and alleviate pain. And that's it. Sure, that was a bit of a long one, sorry. Okay, any questions?